Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another interesting head and neck radiology case. As always, I'd like to start by stating that all of the educational content found as part of this lecture has been completely de-identified in order to protect patient privacy. So this is a patient who presented with headaches and hearing loss. And I have three images for you to take a look at. The image on the left is an axial temporal bone CT image. This has been shown in bone algorithm reconstruction, sort of a magnified image of the temporal bone. The image in the middle is an axial T1 pre-contrast image, and the image on the right is an axial T1 post-contrast image. Note there's no fat saturation that was performed here, but again, the image in the middle is pre-contrast, the image on the right is post-contrast. So take just a couple moments, look at the three images, keep in mind that history of headaches and hearing loss, and try to put this all together. So, what are the findings? What's the most likely diagnosis? And what syndromic association should you be thinking about in this case? Okay, so let's take a look at the imaging. First up, we have our axial non-contrast CT image. And what should be fairly obvious is that we have a large lytic and permeative destructive mass going on in the patient's right temporal bone. And that's sort of denoted here where this yellow arrow is, sort of right in the center of things. And if you look at where the center of this is, it's sort of centered in the posteromedial temporal bone, or sort of the retrolabyrinthine location. Now, as you look carefully, you can see that this is invading the otic capsule, and it's invading some of the inner ear structures. You can see we've lost our basal turn of the cochlea, and the vestibule has been invaded as well. And if you look, you can also see that we've got some spiculated appearing central calcifications. I mean, largely this is a lytic lesion. There's not a lot of calcifications left behind, but there are still a few somewhat spiculated bone fragments left. Now, as we look out more medial to this and more posteriorly, you can sort of appreciate, you have to hallucinate a little bit, but you can faintly appreciate that there's a very thin, almost eggshell calcification that's been pushed medially by this expanding tumor. And that's denoted here by the two yellow arrows. As we take a look at our axial T1 pre-contrast image, we know this is pre-contrast because the nasopharyngeal mucosa, the nasal cavity mucosa is not enhancing. So they always say the nose. So look at the sinonasal mucosa, and if that's not enhancing, if it's not bright, we know it's a T1 pre-contrast. But this mass has a sort of multilocular and bubbly appearance to it. And there are areas within it that have very, very bright intrinsic T1 signal intensity, denoted here with the yellow arrows. If we give contrast, we can see that those previously hypointense areas centrally are now enhancing, and enhancing a bit heterogeneously, but fairly avidly enhancing. And that's denoted here by the yellow arrow. And if you look carefully, there may be some very tiny associated flow voids. It's not really definitive on this imaging, but that is something that on occasion can be seen with this image, with this particular lesion, are flow voids. So put it all together, what's the diagnosis? We have a retrolabyrinthine mass in the temporal bone, permeative, destructive, lytic appearance, again centered retrolabyrinthine. It is invading the inner ear structures. It's got areas that are intrinsically T1 bright, sort of a bubbly appearance. So this is an endolymphatic sac tumor, and these are benign, typically slow growing, but locally aggressive masses that arise from the endolymphatic sac and the endolymphatic duct. Now, these are going to be most commonly sporadic, but they can be associated with von Hippel-Lindau disease. And in cases of VHL, they may be bilateral, not always, but they can be bilateral. And you certainly should be on the lookout for cerebellar and spinal cord hemangioblastomas anytime you see an endolymphatic sac tumor, just because of the increased association of von Hippel-Lindau disease. But again, I want to stress, the majority are still sporadic and non-VHL associated. These can be invasive. They can invade the middle ear. They can get into the posterior cranial fossa, as this was starting to do. They can even get into the middle cranial fossa and invade the skull base. And that's sort of a grading pattern, with middle ear invasion sort of at the lower end of the spectrum and skull base invasion at the higher end of the spectrum. They can also invade or even potentially compress or occlude the adjacent sigmoid sinus, so that's an important thing to be on the lookout for. And these are very vascular tumors for the most part. They're usually supplied by branches of the external carotid artery, like the ascending pharyngeal, but they can also get blood flow through ICA branches. They can even parasitize these branches as the tumor gets larger. So certainly being on the lookout for vascular association, and also these may end up getting preoperative embolization as well to control operative bleeding. So one of the things that can be a little bit challenging, just based upon all the descriptors I've thrown out at you, is trying to determine whether or not you're dealing with an endolymphatic sac tumor versus a paraganglioma, because both can have intrinsic bright T1 signal intensity, both can have flow voids. Usually endolymphatic sac tumors don't have the flow voids unless they're very large, but they certainly can because they're vascular tumors, and both of them can have a permeative destructive pattern to the bone changes. So on the surface, they sound an awful lot alike. Some of the things that I think are helpful clues and helpful discriminators for teasing these apart, first of all, look at where the mass is centered at. A paraganglioma is going to be centered in the middle ear if it's a glomus tympanicum, along that cochlear promontory, or it will be centered in the jugular foramen, or around the jugular foramen if it's a glomus jugulare. Endolymphatic sac tumors, on the other hand, are centered along the posteromedial petrous ridge in the vicinity of, originating from the region of the vestibular aqueduct or the endolymphatic sac and endolymphatic duct. So these have a different location of their center of origin. Now, as a tumor gets very large, certainly there are times that it may be a little bit challenging to tell, but in general, you can see that this is a mass that's located more medially and more posteriorly than we would typically see a paraganglioma. Those are more of a lateral tumor, and those are more of a skull base down at the level of the jugular foramen tumor. So that's a very helpful feature. Look for the center of origin. Also look for the vector of spread. Glomus jugulare paragangliomas have a very characteristic supralateral vector of spread through the floor and into the middle ear cavity itself. Endolymphatic sac tumors tend to grow more centrifugally. They can invade the otic capsule, as this case showed. They can even get into the middle ear, into the posterior cranial fossa, but it's something that originated more from the retrolabyrinthine region, and it's growing out in all directions, as opposed to the paraganglioma that you can find a definitive start point down at the jugular foramen and growing supralaterally. So rely heavily on that center of the mass. Where is the lesion centered at, and what direction is it spreading in? Those, I think, can be quite helpful for really teasing these out, and really to the point you shouldn't need to give a differential diagnosis when you see these. So here's a nice paper that was published by Tauska and Amy Giuliano. And this is just a really nice comprehensive review of temporal bone tumors. So this is definitely one that's worth taking a look at if you're a resident or a neuroradiology fellow, because it's chock full of really nice case content and a nice description of all these temporal bone tumors. So definitely check this one out. Okay, so let's wrap things up. This was an endolymphatic sac tumor. Key imaging features: look for that permeative destructive retrolabyrinthine mass like we showed in this case. It may have some spiculated calcification centrally and eggshell calcification along its posteromedial margin. These will have areas of intrinsic bright T1 signal intensity, and that probably represents a combination of protein and blood products as well as cholesterol clefts within the tumor. And these are avidly enhancing vascular tumors. Typically, it's going to be supplied by ECA branches as the feeders, but they can parasitize ICA branches. And that's important for preoperative embolization purposes. There are some pitfalls to keep in mind. The majority of these are going to be sporadic, but do be on the lookout for additional features that would make you think about von Hippel-Lindau, such as cerebellar and spinal cord hemangioblastomas. And definitely, if they're bilateral, you really need to be thinking VHL. And then also, these can have flow voids if they're large. Don't confuse them for paragangliomas. I threw out a couple of things that I think are really critical discriminators. First of all, use the location. Where is the mass centered, as well as its vector of spread, with the paragangliomas having that typical supralateral vector of spread originating from the jugular foramen, if it's a glomus jugulare paraganglioma, and spreading supralaterally into the middle ear, whereas this tends to grow more centrifugally, but its origin is going to be in the retrolabyrinthine location within the temporal bone. So as always, thanks for tuning in to IU Radiology Case of the Day. I would invite you to follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at radtf.iuhealth.org/COTD. Thanks so much.